Welcome to season 2 of Dr. G at the Heart of Healthcare. We are enjoying summer, and we have a returning guest, Nurse Gerard, Jerry Soucy, our favorite retired hospice nurse. Hello, Jerry.
Good afternoon. How are you, Dr. G?
Awesome, awesome. So glad to be able to talk to you today. Everyone, we are going to hit these topics of sundowning and delirium, one of those words we don't like, right? So we're just going to do some education. It's for everybody. It's for our new nurses in hospice. It's for caregivers. It's for me, a hospice physician, because I get lots of calls and lots of things coming by and I need to educate my team. And so I'm just excited to be able to just glean from your 5 decades of experience in nursing and you being able to educate us. Because one thing I remember about my medical training is I had an old school attending. He told me the treatments may change, but the diseases don't. Like, make sure you know what, the pathophysiology of all these things. And so when we know that, then we can, find good solutions for our patients. So thank you for being here again.
Happy to be here.
Yeah. So first of all, Jerry pointed out to me, do you want me to call you Jerry or Nurse Gerard?
No, Jerry's fine. Sure.
Okay. All right. So he pointed out to me that fast fact number 1 is about delirium. So I was like, wait a minute. Oh my gosh. So I don't know where we want to start. Maybe I'll just tell my story and then you can just go on into things. So I recently got a call, a caregiver, a daughter, worried about her mother, sundowning. She keeps sundowning. Can we just deal with that word? Because I don't remember that word ever in medical school or in residency, but it's something that we use that's thrown around. Where did it come from? Why do we use it? What is it actually?
Yeah, I think it still is in use, in common use amongst all kinds of providers. But I think what they're describing, what people are describing is delirium. Delirium by nature is cyclic, it waxes and wanes. And so to have someone be, cognitively normal through the day, and then, at the witching hour in the evening at a certain time of day, they start, cognitively losing it, or their behavior changes, or, their psychomotor behavior increases. They get agitated or very agitated. But to call it sundowning kind of like, I think, really avoids what it is we're looking at. It's just like using words like confused and agitated without any context. Really, those are kind of vague, unhelpful terms. If I said, I'm confused, does that mean I'm reading some directions and I don't quite understand them? I mean, so yeah, I'm confused. They're complicated directions. Or are you describing something else, like a person really is not like oriented to where they are, or they don't have a sense of the situation. They don't, appreciate the situation. So I would advocate for using delirium to describe delirium. And when people say sundowning, I think what they're really describing is delirium.
Thanks for that. So I wish I could find my med school concept maps. I'm gonna post it one day. But I remember a lecture about delirium. We had 2 in one day from a neurologist, I believe. One was about delirium and one was about dementia. So of course we talked about the different types of dementia in the dementia lecture in medical school. And then delirium, the one thing we learned is it's reversible. It's things we can change. It may be metabolic encephalopathy. It may be this, it may be that, maybe an infection, it may be all kind of things. Actually, there's a mnemonic. I'll have to go find it because it's not in my brain. But I will put it in
here.
Oh, good. Yeah, actually, now I'm remembering there is a mnemonic that we were taught to use for delirium to go through to see what we could reverse.
Yeah.
And so that's what I'm familiar with. Before we go further, I know in hospice, since that's our favorite topic, we talk about terminal delirium and just delirium in general. And then I know there's an ICU delirium. There's all kind of things. Sometimes we may receive a patient from there. What is that? Because I know the comfort kits for hospice, they'll have haloperidol, and we can talk about that later. But what are all these different names? Let's kind of dig in there too.
Yeah. Well, let's. I'm going to say that they are all delirium, the things that you touched on. They're just delirium occurring in different settings, maybe with different causative factors. But let's step back and just say, okay, so what's delirium? And the best definition that I've heard, it came out of the CAM ICU, the confusion assessment method for the ICU, which is, a whole methodology. But basically, in their definition, they say it's an inability of someone to receive, process, store, and retrieve information. That's what delirium is. That a person who is experiencing delirium can't receive information. You can't have a conversation with them. They can't process the words they've heard. They can't kind of tuck them away for later use, or they can't kind of access this to-do list in their mind, and they can't retrieve it. So it's a broken brain. If we went out into the community and used a delirium screening tool, and there are a number of them, but let's say we used a clinical tool and we screened 100 people that we encountered out walking around in the community. We might find 2 or 3 that screened positive for delirium. And it might be because either the person was under the influence of the substance, it was intoxicated, or was withdrawing, was habituated to a substance and was going through withdrawal. Both of those things can cause delirium. So that's out in the community, just a very low incidence. Now let's move into a community hospital, into an acute care setting, and the occurrence or the incidence of delirium goes up to about 30%. And why is that? Well, I mean, the hospitals where sick people go. And so if you're ill, then you have predisposing factor to developing delirium. Maybe, like you mentioned, a metabolic disturbance, hypoglycemia, for example. When people say mental status changes as like an early indicator of something, mental status changes, they're really kind of describing delirium, or an early setting of an early incidence of delirium.
Yeah. They say altered mental status, AMS, altered level of consciousness, change in mentation, or we may ask, are they off of baseline? Like, are they at their baseline? So let me just go to one of these articles that you sent. Again, you have a wealth of knowledge here. And so this is subject palliative care, and the title is Delirium and Advanced Disease. Again, the people we deal with, and it's in the Postgrad Medical Journal. And so it describes delirium. Delirium and advanced disease, while common, is often not recognized or poorly treated. The aim of management of delirium is to assess and treat reversible causes in combination with environmental, psychological, and pharmacological intervention to control symptoms. Delirium presents significant distress and impedes communication between patients and their families at the end of life. A structured approach to recognize, assess, and manage delirium is essential for all clinicians caring for patients with terminal illness. I like that because
that's great. That lays it out.
Yeah, because it's talking about environmental, because sometimes, hey, if the bed is in the living room, maybe it shouldn't be there. Or, if we're not having a routine, maybe that's a problem. Again, there could be a ton of things. I want to talk about the pharmacological intervention because I recently got a call about someone whose sundowning is getting worse. And the nurse said, hey, do you want to add some Ativan? And I was like, my first question is, what's their PPS? Because I want to know if they're ambulating, right?
Yeah.
I don't want to be sedating someone with Ativan and then we're creating a fall risk.
Yeah.
So that's number one. And then, you know, just finding out what is going on to make this patient do that. So, what are the different pharmacological options that we can look into instead of Ativan? Because we know we don't always like that, right? What do you call it? A shot?
I mean, if you're dealing with a benzo, you're dealing with the same neuropathways as alcohol deals with. So, you know, you say Ativan, I think shot of tequila, and repeat it. It's like have another shot.
Yeah.
And you know, when you see someone who's on, say, scheduled Ativan as kind of a behavior control, you know, they're basically getting a shot of tequila several times a day for several days in a row. And you got to, you know, if you imagine yourself doing that with tequila, imagine what that's doing to someone with lorazepam. Let's just step back, because looking at the incidence, we go to about 33% of people in the hospital experiencing delirium because of the different risk factors. And the risk factors can be, again, the illness, the nature of the illness that you have, particularly if it has metabolic processes or if it's an infection, the cytokines and all the inflammation can contribute to delirium. The other thing about a hospital is it's not your home, and you can be very overstimulated with lights that are on 24/7, with all kinds of noises, with people talking out in the hallway. But you can also be sensory deprived. You know, if someone goes into the hospital and they have hearing aids and glasses, and people aren't putting their hearing aids in, or they lose their glasses, they're isolated. And that sensory deprivation can contribute to the development of delirium, as can sleep deprivation. Sleep deprivation and sleep disturbances are an enormous contributor to the development of delirium. To step back to your question about medications, when we look at all the different causes of delirium, all the contributing factors, and pretty much it's the only part of the body that's not involved in delirium or that doesn't contribute to the development of delirium is the brain. It's usually something happening somewhere else in the body. But one cause of delirium, and I mentioned this earlier, is substance withdrawal. And so someone who is has a chronic alcohol intake, who tries to suddenly withdraw, or who suddenly does not have access to alcohol, can slip into the most serious form of delirium, delirium tremens, which is life-threatening, which can cause death. And in the case of treating delirium that's caused by withdrawal from benzodiazepines or alcohol or barbiturates, you give benzodiazepines. There's a whole protocol for managing acute delirium tremens with benzos, but that's pretty much it. If you're looking at delirium and the root cause of the delirium is not alcohol withdrawal, then pretty much stay away from benzos, for the reasons that you mentioned, that they can, if someone's mobile, they can impair their mobility and they can be susceptible to falls. The other thing, you know, I don't know if you've been at these parties, but you know, you go to a party and you know this person who's normally mild-mannered has a couple of drinks, and the next thing you know, they're dancing on a table, or they've got a lampshade on their head or whatever. And the alcohol made them disinhibited. You know, it kind of took away those prefrontal cortex controls. The same thing can happen with a benzo. So if you've got someone who's like has mild delirium, who's just beginning, and you're trying to squash it, and you give them a benzo, you may set them off, because now you've really disinhibited them, and you might very well see the delirium escalate. There was a real good, well, I'm going to say real good. There was a study back in 2017. It was in JAMA, and Dr. Drew Rosile, who's a palliative care physician, he was involved in FastFacts for a while. he summarized the study, and it was a comparison of haloperidol plus a benzo for delirium, for agitated delirium, versus haloperidol alone. And this was in an acute care setting, and I forget the specifics, but essentially what they found is when you give them haloperidol and the benzo intravenously, they get sedated. They hit like a RASS -2 or -3. So they're kind of, sedated. But the group that just had haloperidol and the placebo had a RASS of like between 0 and -1. So that's between alert and calm and drowsy. So you always got to come back to what's the cause and what's the goal. And if the goal for care for someone is, well, they want to react, they want to be able to, the family wants to be able to interact with them. The family doesn't want them to be snowed. Well, that would advise you to stay away from a benzo because it's sedating. By the same thinking, if the person's been very, very distressed and the family's out straight, it may very well be like, what we need for the next 12 or 18 or 24 hours is we need some quiet. This person needs to sleep. It's been 36 hours nonstop. So there you would go for sedation, but you wouldn't do it with, a little 0.5 milligram oral dose. You'd want to give a dose that was sedating. And in this study, it was something like 3 milligrams of IV lorazepam. So that's kind of like a long-winded answer to your question, but it really does come down to what are you seeing? What do you think's contributing to it? What's the goal? And then the other thing is just, escalating your interventions. One of my favorite resources in the bunch of articles that I pulled together over the years is one by Tamara Fong and her colleagues out of the Aging Brain Center at Hebrew Senior Life here in the Boston area. And a couple points that they make is, probably 40% of cases of delirium are preventable. That, the best way to treat delirium is to prevent it from happening. So getting into some of the items you discussed, which is managing the environment, a calm, soothing environment, one that's familiar versus one that's overstimulating or with the television's always on or where people are always talking. So managing the environment so that it is soothing and comfortable, and also having those kinds of interactions with someone. When someone's experiencing delirium, you're not trying to reason with them, but you certainly want to convey non-verbally and verbally, like, it's all right, calm, So those are the two things that come out of that piece that I really appreciate. That you can prevent it. You can do a lot of things to prevent it. Staying on top of toileting, staying on top of pain management. Untreated pain can contribute to delirium. A new medication, someone who's opioid naive, who starts, say, on a relatively high dose of an opioid, may, be at risk for developing, some disorientation. And so, you want to be prepared for that.
Yeah. Thank you for saying that about the untreated pain, because sometimes if we have a patient with Alzheimer's on the service, and I know you have a lot of experience with that being, your profession. And also, if you all remember, Nurse Gerard talked about his wife. And so she was a nurse. He was caregiver for her and nurse. So we have so much expertise here. So I wanna go back to giving specific advice for new nurses who are experiencing this, and then caregivers. Like, how can we help them focus on what's important? There's, we have our nurses, our other nurses online that are educating the community about like terminal delirium. And I know you don't like to switch it up, but sometimes a person may not have dementia, maybe they're on hospice for cancer or for something else, but when they are transitioning and then they become bedbound and they're unconscious most of the time, they're reaching for things. They're doing all those things. What do we do when we're not trying to reverse it, when they're actually transitioning? How's that different for our new nurses and caregivers? Because everyone wants to do something.
Well, yeah, that's true. And sometimes the most important thing to do is simply to be there. It's not do nothing, but you don't necessarily have to mess with something, but certainly be there. You know, in the case of someone who's, say, reaching, they're not fully conscious. The first question is kind of like, okay, does there seem to be some distress associated with that? Can you see that in the face? Are the gestures like alarming? I would approach those different. I would approach that differently than if, you know, someone was just kind of doing this thing. I think the idea that the hospice nurses are preparing families for this at the end is a good start. I think, you know, when we look at that levels of incidence, you know, from just a few percent in the community to about a third in a hospital to about 2/3 in a rehab or skilled nursing setting to about 75% in the critical care unit. And again, you just think of all the risk factors, all the noise, the more severe level of disease, the more powerful drugs. But the highest instance of delirium is in our field. It's with end of life care. So I think for any nurse walking into a home, it's like, I'm going to anticipate delirium until proven otherwise. Because, you know, with 80-90% chance of delirium at some point in the hospice stay, it's like walking into a casino. You know, if you've got 80-90% chance of making the right bet, go ahead and make the bet. You're probably going to be right. So be aware that delirium is very frequent in hospice, and that's one of the things that kind of turned me around. Well, it certainly kind of like made me think that when I started in hospice, I anticipated that the most challenging symptom management problems would be, say, pain related or maybe dyspnea. But the incidence of delirium is much higher than either respiratory or pain symptoms. And it kind of like crosses diseases. So anticipate it, appreciate that you can prevent it or forestall it for the most part. Let's say someone in the early part of their hospice encounter has that peaceful room, has that really intentional kind of interaction and everything, and they're comfortable. So we're keeping delirium at bay. But as they decline, their own defenses kind of fall apart. So maybe now, and you think about it, if someone's dying, what's going through their minds? And, you know, all of that activity to me kind of like can contribute that those thought processes spinning out of control can become delirium. So expect it, prevent it, manage the environment, instruct the family on the importance of managing the environment. And also because the family's there for longer than we ever are, making them, you know, aware to report, you know, concerning changes in behavior, in someone's communication, because oftentimes, again, those are like the first signals that something's going on. And if you catch it early, you can reverse it, you can prevent it from escalating. Because one of the things that, you know, it's a difficult experience for the patient. It's probably the leading cause of emergency room visits amongst the elderly, you know, mental status changes.
And they just 911 them out. I remember from residency, like the chief complaint would be alter mental status from a sniff. And it's like, okay. So yeah, I thank you. I remember what I wanted to say. Thank you for mentioning the untreated pain, because when the team is talking about, They're agitated. They're agitated while they're getting their bath. Bingo. That's the number one thing.
Mhm.
So let's schedule Tylenol. If that doesn't work, let's do this, because sometimes people can't verbalize that, especially if they're on service for, Alzheimer's or something of that
Yeah.
nature. So a lot of you give a lot of high level advice for nurses. Do you have any advice or resources for caregivers? They may not have a medical background, but
Yeah.
they're devoted, they're taking care of their parent or their spouse.
Sure.
What can they do, because they are there all day,
Yeah. Well, there are two tools, validated assessment tools, that I think are central to kind of working in this field and dealing with dementia. And one of them was developed in the perioperative setting, the Richmond Agitation Sedation Scale, or RASS. I think of it as a thermometer, and the 0 point is the point where we are alert and calm. That's someone who's taking in the environment, they're aware of what's going on, they're not distressed in any way. And then kind of going up from that, the way like a temperature rises, we go from alert and calm to restless. And restless could be someone who they look fidgety, they're biting their nails, they're tapping, they can't sit still, they're tapping their fingertips, they're, like this, they're kind of nudgy, as my mother would say. But it's kind of like contained. So that's like +1. +2 in RASS is called agitated, but it's very specific. Agitated in the context of RASS means non-purposeful movement. You were describing the grabbing. That's, how does that make sense? That's non-purposeful. Or ineffective movement, like someone who's trying to get out of bed, but they've wedged themselves between the two side rails. You and I, if we were sitting there like, okay, I want to get out of this bed, we'd figure it out. But when someone's agitated and, they're trying to get out and they really can't pull it off. Then the next level up in RASS is very agitated. And very agitated means they're a danger that they could hurt themselves. Someone who's thrashing around in bed or could throw themselves out of bed, or they're pulling out an IV or pulling at their Foley. They could hurt themselves. That qualifies as very agitated. And then the top of the scale is combative. That's when you or I could get hurt. Then going in the other direction from 0 down, you've got -1, which is drowsy. Someone who's drowsy, they're there with their eyes closed. You use your voice, you say, hey, Jerry, wake up. It's time to take your meds. I open up my eyes. I can verbally interact with you. I can follow simple commands. I'll take the pills. I'll drink the water. And, and it lasts for more than 10 seconds. And then we're done. And I kind of like go back. So I'm drowsy. Then the next levels, -2, 3, and 4, are levels of sedation, mild, moderate, or deep. And mildly sedated is like procedural sedation for wisdom teeth or a colonoscopy, where I can hear voices and I can kind of cooperate with simple commands. Okay, Jerry, we're going to turn you over, just grab the side rail, and I can kind of do that. But beyond that, I'm not interacting. So that's mildly sedated. Moderately sedated, the only response to voice is some kind of non-specific. Maybe my eyebrows arch, or I have a facial expression, or I move. Your voice gets through, but we're really not interacting. And then deeply sedated is I don't respond to voice, but physically, if you touch me, I respond. If you squeeze my hand, I might squeeze back. Or in a neurology setting or a neurosurgery setting, we might do something painful to see if they're a withdrawer, right? To see if they're going to come back up from an injury. And then, -5, RASS -5 is like unarousable. There's no response to voice or any kind of physical. And in a way, that kind of descent in RASS is a lot of times what the end of life trajectory looks like, or ideally looks like. People just slowly get deeper and deeper asleep until they're unresponsive. So that's one tool. And the beauty of RAS and this tool in particular, and tools in general, is it lets the hospice team and the family and the caregivers kind of have a common language. It's like, okay, you don't have a healthcare background, but you're an adult who can learn. And these are some important concepts. And here's the reinforcement. Here's like a resource card with those different levels, so that you can say, yeah, he was agitated for a while, but then he was restless, and now he's alert and calm. And we know what we're talking about. So that's one tool. The other,
I like that one. I want to start using that one.
It's yeah. If when people are on the same page, it's amazing, what can happen.
What a concept.
When we don't understand each other, well, he said he was agitated, but we got to understand what we're saying.
I want to start using that. Yeah. Mm-hmm.
The other tool that I really like, and again, this one goes back about 20 years, I think. It's called NuDesk, the Nursing Delirium Screening Scale. And it came out of an oncology setting, an inpatient oncology setting in Montreal. But it's been tested in perioperative settings. And I think it's perfect for hospice. And here's what this does. And I got to look at my cheat sheet because I haven't used it in a while. But NuDesk this is an assessment you can do from the doorway in about a minute. It's an observational checklist. And the first thing you're looking at is, and maybe you have to interact a little bit, but the first thing you're looking at is just as their level of orientation or disorientation. And for any of these things we're looking at, we want to know, is it absent, in which case it's 0? Is it mild to moderate, in which case it's 1? Or is it moderate to severe, in which case it's 2? All right, so it's either scored 0, 1, or 2. And there are 5 different things. So we look at orientation. Do they appreciate their situation? I have heart disease, I have cancer, I'm in hospice. Do they have a sense of their situation? People pretty much, they don't lose their sense of who they are. Do they know where they are? And do they have a sense of time? And time is easy we could lose track of time, but do they have a sense of the season or the month? So that's the first thing you assess, is their orientation. The next thing you assess is you're looking for inappropriate behavior. And that's the term they use, is inappropriate. So inappropriate means different from their baseline. Is someone who's normally calm, are they behaving in a more agitated, psychomotor agitated state? Are they doing like the non-purposeful movement? Or delirium can also be, you can have the hypo form of delirium, hypodelirium, where people aren't agitated at all. They're very much, dulled. So you're looking at the behavior. Does it, deviate from their baseline? The third thing you're looking at is their communication. Does that deviate from their baseline? Someone who's normally, very calm and collected, are they speaking loudly? Are they swearing? Is it gibberish? So you're looking at communication. The next thing is perception. Illusions, delusions, hallucinations, are they present or not? And then the fifth thing you're looking for is psychomotor retardation. This slowness, this dullness. Do they look like they're sedated? Do they look like they're groggy? Because again, that can be a form of delirium. So with this as a screening tool, the idea behind it, if someone scores 2 or above, that's like screening positive for delirium. It's like, look more closely. And, if you think about it, if someone is mildly disoriented, like, hey, Jerry, can you tell me where we are? Can you tell me what's going on? And at first I don't have a clue, but then I come around. So you score that as 1. And then, going down the list, we get to say perception. And I say, well, there's a dog in the corner looking at me and I don't like that. And maybe it's a coat on the back of a chair. And you show me it's a coat on the back. Oh, silly me. But you score me 1. All right. So in our encounter, I've scored only a 1 for just 2 things: inappropriate, altered perception and disorientation. But it's kind of like I'm sending out some pretty strong signals that I'm developing delirium. And so this is where, you start to assess, okay, is there something physiologic going on, an infectious process or a metabolic process? Are we not managing their pain? You mentioned the mnemonics. The 2 that I've seen for med students, one is I watch death, and like every letter stands for, like I stands for infection. That's the only one I remember. There's another one called where it's delirium, where each letter has a cause. In hospice, I would simplify it and say drugs or lack of drugs, either reduced sensorium, like sensory deprivation, or overstimulation, or sleep deprivation, kind of like that cluster, or something about bowel and bladder. I was working in an inpatient setting, and I came in, and a patient had transferred into our unit overnight from the floor for mental status changes. And when I arrived, the patient was in wrist restraints, soft wrist restraints, and they were very uncomfortable and they were thrashing around. And their family member was also there, and they were very upset. And we started figuring things out. And it's like, okay, this person's been in the hospital now almost 48 hours. When they were out on the floor the first night, they didn't sleep. And they came to us on the second night. So they came to us sleep deprived. And then as I was doing my assessment, I thought I heard this patient say bedpan. And so it's like, okay, let's try it. So we got him on a bedpan, and wouldn't you know, he was impacted. So I disimpacted him and looked at the family member and said, he's my only patient today. I'll stay right here. He's hooked up to monitors. Let's let him sleep for the next 4 hours. Let's let him sleep till noontime and see where we are. And we did. And he woke up at noontime and he was a different person.
Oh, I love that story. Yes. Because that's what we have to think about. Because sometimes, again, people get caught up. That's why I did this episode. People get caught up in the sundowning. So then maybe if it's at 10 o'clock in the morning, like you said, we're not looking for things to fix or whatever. But that's important. Like, let's look at them. What do they need that they're not able to communicate to us right now? And while you were talking, I was able to find these mnemonics here. And so I see one that says pinch me. I see one that is the words of delirium, broken down: drugs, epilepsy, electrolyte imbalance, liver failure, low oxygen, infection.
So many.
R for retention of urine or fecal, like you just mentioned, the impaction. I, intracranial, something's going on here. Uremia, something's going on there. Metabolism. And then the pinch me: pain, infection, nutrition, constipation, hydration, medication, and environmental. And then this other thing is what I recall: comparing delirium versus dementia. So the onset, again, delirium is rapid. Like last week, thumbs up. Thumbs up. Last week the person wasn't like this. It's one thing when someone changes over years versus last week they were good and now they're suddenly changed. The course, here's that sundowning, fluctuating, cyclic, duration, it's reversible. Of course, dementia, we know it's irreversible. Their level of consciousness or their cognition that we often talk about, in our reports, it could be normal in dementia, but it's altered in delirium. Attention, memory, psychomotor changes in sleep. So all those things are, very high level. If I had to vote for someone to take away from this today, I would say look up that RAS. I'll put up something there in our show notes. I'll put a link to that in the show notes, just so we're all on the same page, right? Because we want, as healthcare providers, we want to be on the same page with our caregivers. We want to empower them while they're at home. We want to avoid unnecessary, emergency room visits, and just work together. So thank you for all this stuff. Like, this was like a lecture here.
We could, we could talk about this. I wouldn't even put a time limit. I mean, it's a fascinating topic. There's a lot to talk about. There's a lot that's going on. I think it's ironic too. Dr. Sharon Inouye developed CAM, the confusion assessment method, in the early 90s as a medical resident. And because she saw, like, we're talking about this thing, but we haven't given it a name, and we really haven't, kind of like taken a structured approach to it. So she came up with the confusion assessment method, CAM. And I don't know if she thought, well, that's taken care of. And, like 30, 40 years later, no, we do a really bad job in every setting, recognizing it, preventing it, managing it effectively. And certainly in our setting, it's probably, the family's worst nightmare would be seeing their loved one in a state of agitated delirium, because it's just really distressing for everyone around.
Yeah. Well, thank you so much for coming back. I know we have a lot more topics to talk about. Yeah. But if you had any final last word for anyone listening, I'll let you have the last word, and then we'll sign out.
Well, I guess let's just play off of the idea of, in the Comfort Kit, people treat the haloperidol concentrate like it's explosive nitroglycerin. There's some, or to touch it in such tiny doses. You don't have to worry about the haloperidol as much as you have to worry about the lorazepam. So I would say, hospice nurses out there, be thoughtful about where and how you think about using that one, or asking for that one, or suggesting that one.
Right. All right. Well, we're going to sign out on this because, like I said, I think you need to drop a course on this. I'm sure you have a blog on it, because we are over our time. We just want to give them bite size. So thank you for joining us for this discussion. What's our joke? A doctor and a nurse go to the bar.
Yeah. A nurse and a doctor go into the bar, and the bartender says, "What'll it be, doc?" And the nurse says, "She's a doctor."
All right. So good to have you. Signing out on this episode of Dr. G at the Heart of Healthcare, and Nurse Gerard in Boston. Peace.
So take care.